Hi everyone. So this video is on approach to learning anesthesia. Before this, whenever you were going in the operation theaters during your MBBS postings, I'm sure that you were more interested to see what is happening on the surgery side because that is what we were doing. But now, since your post graduation in anesthesia has started, so you'll be towards the anesthesia side, and you'll see that there are so many new things you'll be seeing which previously you didn't pay attention to. Let me just share my screen. So there are a lot of new things one faces when enters the anesthesia learning environment because previously you were not bothered about what is happening that side. So it may cause anxiety in the beginning, but as you move systematically, you'll see that everything is manageable and not difficult. So in the beginning, you'll see that there is an unfamiliar environment because as soon as you enter, you'll see lot of equipments, the big anesthesia machine which is kept there, the electronic monitors, lots of anesthesia drugs which you have only heard about sometimes, but you didn't pay attention to, and the equipment cart. So these are all things you'll be seeing daily. This is the big anesthesia machines, the monitors, which are always beeping and producing some or the other alarms, and a lot of drugs you'll see on the drug tray, which will be reading with time, and the equipment card, lot of new instruments you'll be seeing. So all these can cause anxiety and you can have some tensions in the beginning. But if you already know what you're going to face, it'll be a very smooth run. You'll find everything very interesting and very exciting. So yes, so unfamiliar environment is something which you'll be seeing. Then the direct responsibility for patient management, because when you enter into anesthesia, sometimes you are with your seniors, but sometimes the seniors are not with you. So you are alone. So that time, the responsibility for patient management is solely on you. And then you can have some anxieties. But if you already know what is expected out of you, it'll be easy for you. Time pressure. In the starting, you'll be not knowing about the various lines and the procedures, so it'll take time, and the surgeons will always be there on your heads that start the case early, so it'll be a pressure in the beginning, but slowly you'll learn everything and things will be easy. And then the fear of unknown on our unpredictable critical event. So this is also something which you'll see in your daily practice, that something or the other may happen because it's a human body. So a lot of physiological and things are happening, like sudden hypotension. In the beginning, you'll not know what to do when you are alone or with your senior and there is sudden hypotension. But slowly and gradually, you'll understand everything and things will be easy. So for structured approach to anesthesia care, there are 4 things. If you do it systematically, that things will be very easy. So what is about whenever we see a patient, there are 4 things that comes in our mind, that we want to know about the patient, how the patient has been till now. Then that is the pre-anesthetic evaluation, pre-operative evaluation. So it is PAC, pre-anesthetic checkup. Before you give anesthesia, you check the patient. This is the most important part in the patient management. And sometimes the PAC is done by you, sometimes it is done by somebody else. So it is a piece of document which has everything written necessary to conduct the case. So it is very important. The first one is to do preoperative evaluation. Then after you have seen the patient, after you know about the patient, you have to decide how you're going to go about the anesthesia. So create anesthesia plan is the second one. Then after you have seen the patient and prepared and planned what you're going to do, then you have to prepare the operation theater according to what you have planned and the patient profile. And lastly, when everything is in place, then you take the patient inside the operation theater and manage the intraoperative anesthetic. So first of all, we come to preoperative evaluation. As I've said, that this is the most important part during your conduct of the case, because this is what will tell you how you're going to manage the case. So that piece of sheet contains everything necessary. It has diagnosis, it has the surgery which is to be taken place, Then it has written about all the comorbidities the patient has, and it will have the general physical examination, which will have blood pressure, pulse, weight of the patient, because many drugs, all the drugs actually are given according to the weight of the patient, height of the patient. Then the systemic examination, then you'll see about the respiratory system, then the cardiovascular system. And then there is one thing very important, that you have to see the airway of the patient, because you have to give you have to intubate the patient. You should know that how easy or how difficult it is to intubate the patient, that is to put the endotracheal tube. So airway examination and the spine examination. Spine is important to give spinal or epidural. So in the pre-anesthetic sheet only, it is all written, because you have only written it, that how the patient is airway wise and spine wise. And then the systemic examination you have to do, that you have done. Now you have to do the right about the drug allergies. You have to ask the patient about if the patient is on any addictions, smoking, alcohol. Then the drug history of the patient. Then there are investigations. There are a lot of investigations you have to see. So according to the patient and the surgery which is to be taken place, the age and everything, you have to order for certain investigations. Then you have to further, then you have to give the preoperative advice. In preoperative advice, you give about how much nil per oral is required, and what pre-medication, what drugs you want the patient to take before coming to you in the operation theater. So everything is written on that sheet, and that sheet is a very important piece of document. So it is all there in the preoperative evaluation. So in the first 1 or 2 months, you won't be doing it much, but later on, it will be an important part you'll be doing. So you have to learn it very well. So the goals of the preoperative evaluation are assessing the risk of coexisting disease. So diabetes, hypertension, asthma, hypothyroid, you have to see. Then modifying the risk if it is out of control. If you can control it, you can optimize it before taking for anesthesia, because you want the fittest possible patient for anesthesia, because so that the drugs and whatever the surgery is taking place, they cause least harm possible. So you have to modify the risk, addressing the patient concern. Sometimes patients are very anxious, and that time you have to tell them, you have to counsel them, you have to ask them. They will tell you, they may have some history that previously they had something during the previous surgery. So that is very important, because most of the times, if like drug allergies, some people are allergic to xylocaine and some people are not. Some people are allergic to certain antibiotics, so you have to take care. Some people already know if they have undergone any reaction previously na. So that's why it's very important, and discuss the options for anesthetic care. Sometimes it is like that one case can be done under regional also and under general anesthesia also. So you have to discuss with the patient also. There are patients preferences also. So learn some specific questions to understand patient and the proposed surgery. Okay. So because like when you take any patient for anesthesia, there are 4 or 5 basic questions which you must ask. Like you should always know the indication for surgery, if it is emergency or elective. Suppose if the patient is for esophageal fundoplication, for gastroesophageal reflux disease, so you know that the patient is having a reflux. So in the pre-medication, you want that the patient should be given antacid. And there is something called rapid sequence intubation. It is done in patients who have high risk of aspiration pneumonia. So that's why you will be learning about this later. So basically, you want to know the indication for surgery and the type of surgery, emergency, elective. Suppose it's a hand surgery, then you can plan for local anesthesia, nerve block, or general anesthesia. Suppose it's an emergency surgery like appendicitis, so you don't want to test unnecessarily. So you just want the basic investigation so that the patient can be taken up early. And then there is some inherent risk of this surgery, like the CABG, bypass surgery. So in this, patient may have intraoperative death or stroke or myocardial infarction. So actually, before every anesthesia, before every surgery, you take an informed consent. Informed consent means that you take permission from the patient that in case of this thing, these things can happen. And so I have already told you all this about, and after hearing all this, you are ready to undergo anesthesia. You are ready to undergo surgery. So patient has the full right to know about his disease, about the surgical procedure, about the risk associated with the surgery, so that he can take the responsibility, he can take the decision. And then a surgery like cataract is very low risk. So there is no risk of any major organ damage. So everyone should know how risky the procedure is. So it is their right. Then the coexisting medical problems. If we need to modify the plan, like the hypertensive patients during intubation laryngoscopy, they can have accelerated hypertension. This can lead to intracerebral bleeds. So that is why you have to control the laryngoscopy that time, the intubation response, by giving Zylocard or other means. So you should know. And then the history of anesthesia before or difficult airway. As I've told you, like some people who have already undergone any surgery before, they know that this was difficult for me, so I should tell this person about this thing. So there are certain things you must see before the patient for anesthesia, which are the comorbidities, because you should always know what the comorbidities of the patient are. You should always know about the airway and the spine examination. You should always know the nil per oral, and you should always know the allergies, patients' allergies, because they can be catastrophic if we miss them. So after this, the pre-anesthetic checkup, it's the creating the anesthesia plan. Now we have to plan that what kind of anesthesia we want to give. So we can plan general anesthesia, regional anesthesia, or something else. So suppose if the patient is coming for laparoscopic cholecystectomy, it is a very common surgery done in all the hospitals. And if suppose if the patient is asthmatic also, so the concerns for this patient are that he has to undergo laparoscopy. Now, laparoscopy has its own concerns because pneumoperitoneum is done. You will be seeing in the operation theaters, and we'll be reading about this a lot in detail. And patient is asthmatic also. So we have to plan accordingly. So preoperatively, before we take the patient for anesthesia, we want to give the patient some pre-medication. We want to give midazolam for anxiety, and we want to give the bronchodilator puff. So we ask the patient to continue the bronchodilator puff the patient is already taking before coming to the operation theater. And then the intraoperative course, the IV access monitoring done in all the patients, induction, whatever we plan for, like fentanyl, propofol, neuromuscular blocking drugs, airway, first of all, face mask for bag and mask, then under direct laryngoscopy, endotracheal intubation. Nowadays, even supraglottic airway devices are used. So we have to decide everything beforehand. For management, we can plan for sevoflurane, isoflurane, fentanyl, and neuromuscular blocking drugs. Now, this is also important because the patient is asthmatic, and certain neuromuscular blocking drugs releases histamine. So we have to choose wisely which neuromuscular block we want to give to this patient. And then there is extubation. Extubation, before just extubation, we give ondansetron to prevent post-op nausea, vomiting, and then reversal, neostigmine plus glycopyrrolate. So in this particular case, possible intraoperative problem can be bronchospasm, because the patient is asthmatic, the airway is very reactive. So we have to be prepared that if at all patient will go into bronchospasm, I will increase oxygen, I will increase the volatile anesthetic, I will ask the surgeon to stop the stimulus, because surgical stimulus itself is may itself cause bronchospasm. I will give bronchodilator puff, and I will adjust the ventilator settings. So these all things should be on your tips. Then in the post-op period, you'll plan what pain control measure you want to give, where to shift the patient post anesthesia care unit, and then to ward. And in the second scenario, like if you want to give the patient regional anesthesia for right shoulder arthroscopy for chronic pain. Now it's a right shoulder arthroscopy. So you want to give regional. So you want to give an interscalene block. There are various blocks. So to block the brachial plexus, you all know that brachial plexus supplies the arm. So there is a block interscalene under which shoulder surgeries can be done. So in the pre-medication, again, you want to give midazolam for anxiety, intraoperatively interscalene block. So you have to plan previously only before you take the patient inside, because you have to prepare the needle, you have to, local anesthetic has to be there, nerve stimulator or ultrasound, whichever mode we are using, that thing has to be inside. Sedation, you can plan whatever midazolam, fentanyl, and in the post-operative period, you have to decide how you'll be controlling the pain. Sometimes you leave the catheter inside and give top-ups post-anesthesia care units. So now we know that we know about the pre-anesthetic checkup of the patient and we have created the anesthesia plan. The next is preparing the operating room, OT room. Okay? So in this, there are different things like basic room setup. Now, before you take the patient inside, you want your OT to be perfect for that patient. So the basic room setup means there are certain things you have to see in all the patients, whatever the patient, like suction. Suction is very important because the patient may drown in his own secretions and there may be blood in the oral cavity or the pharynx, and then there is chances of aspiration pneumonia. The blood may trickle down. So, or the secretions may trickle down, and you want to prevent it because it may lead to laryngospasm, bronchospasm, and even death of the patient. So, suction is very important. You always, before taking the patient, check that the suction machine is working and adequate pressure is there. We'll be learning in very detail about all these things. So, oxygen has to be there, sufficient amount. So, the pipeline pressures at least 50 psi, and the cylinder, E-cylinder, 2000 psi must be there. Anesthesia machine, you have to check. This you will have to check daily whenever you enter the operation theaters. The airway card, you have to see. So the airway card, when you enter initially, you will be like, there are a lot of things, but everything is important on that airway card. See, the laryngoscopic blades, there has to be 2 laryngoscopic blades and the 2 handles. Then there has to be two size endotracheal tubes, then 2 size laryngeal mask airways, then oral airway, then nasopharyngeal airway, the lidocaine and KY jelly, tube, tapes, bite block, tapes, then stillet, bougie. Lot of things are there. Just when you will go to the operation theaters, just take a look and see it thoroughly because that is very important. Then ambu bag, the resuscitated equipment. It is the self-inflating bag. It is very important in all the operation theaters to be there because it is self-inflating. So sometimes accidentally, suppose if the oxygen finishes or there is some problem with the pipelines or anything and there is no oxygen, then this is the only equipment which can provide positive pressure ventilation to the patient who has been given neuromuscular blocking drug. So if patient can't ventilate on his own. So this is the only equipment that is of use that time. So take care that ambu bag is always available in your operation theaters. And the defibrillator, every day when you go to the operation theaters, always charge the defibrillator and see that it is able to deliver the said current. Because there may be certain arrhythmias in which only defibrillator works and nothing else. So you're preparing the operating room, OT room is the most important thing, is very, very, very important. So, and it is solely the responsibility of the first year PGs. So that's why it's a lot of pressure and a lot of responsibility. So after all this, there is IV access and monitors. So you have to see that to monitor the patient during anesthesia, you have the ECG pads, BP cuff, pulse oximeter probe, capnography, temperature probe, and all the monitors are in the working position and the alarms are working. Then basic route setup, IV anesthetic. Then you have to prepare the drugs. For drugs like pre-medication, midazolam, opioids, fentanyl, induction agents, whatever you choose, propofol, thiopentone, etomidate, according to patient profile. The neuromuscular blocking drug, whatever you choose, acetylcholine, rocuronium, decuronium, atracurium, vasopressors for sudden hypotension, mephentermine, ephedrine, phenylephrine. Okay, so there is this drug tray which you prepare. So on one side, there are these pre-medication drugs like glycopyrrolate, ranitidine, metoclopramide, midazolam. In the front, towards you, are the induction drugs, the fentanyl, propofol, decuronium, atracurium, whatever you decide. And then on one side, there are emergency drugs. Atropine, if the third patient undergoes bradycardia anytime, if there is a arrest, you have to keep adrenaline. Then methamphetamine for BP. There is hypotension. Xylocaine you have to keep for to blunt the intubation response or for certain arrhythmias. And then hexamycin you have to keep. This is kept to prevent laryngospasm. If sometimes the patient has laryngospasm and by no other means it is getting corrected. This is very important. And this varies from hospital to hospital and OT to OT. So how many drugs you have to prepare. So there are certain tips while you prepare the drugs, that always label the drugs with concentration. You just don't only write the name of the drug. You also write the concentration of the drug. So like xylocaine. Xylocaine comes in 2%, but sometimes you make it 1%. So don't just write xylocaine. Write xylo 1%. That is important. So that it is not necessary that you are making the drug and you are only using the drug. Somebody else may also use the drug. Okay. So important thing is that whatever percentage a drug is, it is add 10, like 1% is 10 milligram per ml. Because by definition, 1% is 1 gram in 100 ml. So 1 gram is 1000 milligram. 1000 milligram in 100 ml, which means 10 milligram per ml. So suppose anything like you can say propofol. Propofol is 1%. So propofol is 10 milligram per ml. Xylocard is 2%. So it is 20 milligram per ml. So second is 1:2 lakh. 1:2 lakh, you can just cram that it is 5 microgram per ml. So like in xylocaine, which comes with epinephrine, you will see that epinephrine is 1:2 lakh. Adrenaline. Adrenaline comes epinephrine, which comes in 1 ml ampule. It is 1 milligram. 1 milligram per ml. 1 milligram means 1000 microgram per ml. So it is written as 1:1000. Okay. You'll learn this, you'll remember this once you enter your OTs. So it won't be difficult. Then we have learned about pre-anesthetic checkup, how you are going to plan your management, GA or regional. Then you learned about third thing was preparing the operation theater. And the last and the fourth thing is managing the intraoperative anesthetic. How you're going to manage. So for that, it will be different for every case. So you have to be vigilant, watchful, and alert. It is the most important monitoring according to ASA standards also, that a vigilant anesthetist has to be there. Decide whether to change patient management at any point. You have to be always on your toes. Maybe you have to change from spinal to general anesthesia at any point. So interpret findings regularly. You have to keep a good documentation of whatever is happening and diagnose the problems. If you are putting a close watch, then you will diagnose the problem before anything catastrophic occurs. But if you are very casual, then you'll have to manage a difficult situation every time. So it is better to be vigilant. Act and repeat evaluation. So the phases of anesthetic care includes pre-operative, intraoperative, and post-operative. In the pre-operative, pre-anesthetic checkup, the most important, choice of anesthetic, choice of anesthesia, GA, regional, or something else, and the pre-medications. In the intraoperative, physiological monitoring, vascular access, general anesthesia, so whatever things are required, how you'll induce, how you'll maintain, and how you'll extubate the patient. And the regional anesthesia, what type of block you want to give, what type of needle, local anesthetic, and the post-operative pain control method. The pain control method has to be decided pre-operatively or intraoperatively. How you're going to control the pain in the post-operative period. Special monitoring. Some patients require special monitoring, like CVP monitoring, BP monitoring. Some people require urine output monitoring. So you have to decide all that before you ship the patient to post-operative room, whether the patient needs to be, where the patient needs to be shifted. The patient needs to be shifted to daycare ward or room or ICU or HDU. This is all you have to decide. So this was all about this video. In this, we have seen how you're going to slowly get accustomed to what you have to do daily so that there is less anxiety and you're always prepared for anything happening inside your operation theaters, and your life is very much smoother. So thank you everyone, and keep watching, and do like, share, and subscribe. Thank you.